Thank you for the opportunity to be here and presenting to you. So I would be touching upon many things on choroidal imaging in pachychoroid spectrum of diseases. So we all know that now it is an ever expanding spectrum from pachyepitheliopathy to CSC, pachyneovasculopathy, PCV, focal choroidal excavation, peripapillary pachychoroid syndrome, and very recently pachyvitaliform maculopathy. So common to all these diseases is presence of reduced fundus tessellation, and you have a increased thick choroid in this, generally more than 400 microns, and the classic hallmark of choriocapillary compression overlying a dilated Haller's vessel, and ICG angiography showing a early delayed arterial filling and then areas of choroidal vascular hyperpermeable areas in a patchy fashion. So coming to the first entity, non-specific RP changes, that is pachychoroid pigment epitheliopathy, with or without serous PEDs, and these are considered to be form a first of CSCR and mainly in the fellow eyes of CSC. So what you look for is overlying a thick choroid on pachychoroid and vascular hyperpermeability on ICG. You have this autofluorescence showing RP defects and degeneration or RP changes. So this is in the absence of subretinal fluid. Also there are other signs like a pachydrusen or a drusen-like deposits that you see overlying this pachychoroid, and this pachydrusen larger than 125 micron is different from the soft drusen that we see. So these are, the telltale signs of this because it is different from a AMD soft drusen, which is around the fovea. It's collected and overlying a thin or leptochoroid. You have a thick choroid and hyperpermeable choroid, and you see these singly or in pairs distributed across the posterior pole. This is a difference. And then another entity in this scenario is pachyvitaliform maculopathy, where you see this yellowish lesion under the fovea, and OCTA is important to rule out a neovascularization, but the importance is that or the predictive of a pachychoroid geographic atrophy. This is the picture after 6 years, and it goes in for a CRORA or a pachygeographic atrophy. So this is a case example here. You see this patient who has multiple pachydrusen, and you see these areas of CRORA. So this again the other eye. I showed the fellow eye of the patient, but this eye is having a PCV lesion with again a CRORA. You are looking at a pachychoroid geographic atrophy in this setting. So these images shows the pachychoroid, presence of pachydrusen, areas of outer retinal atrophy and RP atrophy. So this is the kind of these lesions are lesser than the age-related CRORA or geographic atrophy. The other eye showing RP undulations, double layer sign, and also adjacent areas of geographic atrophy, pachychoroid geographic atrophy. Here you see a leaking PCV, and here you see a geographic atrophy. OCTA showing the branching neovascular network and the polypoidal lesion. So this OCT and a combination of autofluorescence shows this lesion, which can be seen in a plain pachychoroid or associated diseases like PCV, pachyneovasculopathy, or CSC. So this is the atrophy on autofluorescence. So moving to another entity, acute CSC or simple CSC, you have only a neurosensory detachment on OCT. But moving to the and a point leak on fluorescein. But when you move to the other variants like a fibrinous variant or a bullous variant where you have exudative detachment, the OCT signs including hyperreflective subretinal hyperreflectivity in the neurosensory detachment or a serous PED with a hyporeflectivity. So in this setting, diffuse RP epitheliopathy, this is a typical chronic CSC where you see the signs on OCT like, intraretinal fluid, a chronic PED, outer retinal photoreceptor elongation that you see on OCT, or even a foveal thinning and ellipsoid zone disruption. These are all poor biomarkers, and especially in the absence of subretinal fluid, you see this large cystic space. This is something called cystoid macular degeneration, poor indicator or poor biomarker in the setting setting of CSC. These are cases where you have the subfoveal PEDs and on OCT that you see, and subretinal fluid as well, and showing a choroidal vascular hyperpermeability and diffuse leak on fluorescein angiography. So the only effective treatment you see in this serous PED to disappear is PDT, which causes the disappearance of PED as well as subretinal fluid. So around 90% success in our Indian eyes, and as well as compared to the Western literature. So in this regard, when you see another biomarker that is acquired vitiliform lesions or AVLs under the retina and between the RPE. So when this is a biomarker that it may not respond well to PDT. This is before PDT and after PDT. After 1 month, there is no response in this case. Another, as I already mentioned, this is a clear-cut case of cystoid macular degeneration, poor visual outcome in these patients. So coming to the choroidal biomarkers, you have either a diffuse choroidal thickening or a focal choroidal thickening. It may just be a focal choroidal thickening, and this thickening can be reversed with photodynamic therapy with the pachyvessel diameter reducing post-PDT at 3 months. So another biomarker is something called choroidal hyperreflective foci in the inner choroid as well as in the subretinal space, giving some thought that this is an inflammatory origin in chronic CSC, but in the consensus is that it's an overwhelming choroidal vascular hyperpermeability resulting in cellular and lipoprotein extravasation, causing a hyperreflective foci in the choroid and outer retina. So talking about the focal choroidal thickening, you see this nasal macular choroidal thickening is a hallmark of peripapillary pachychoroid syndrome with overlying intraretinal subretinal fluid. The OCT, this is a classic case wherein on either side of the optic nerve you see this intraretinal subretinal fluid and the macula, and the autofluorescence showing the peripapillary RP mottling and peripapillary pachyvessels and choroidal vascular hyperpermeability. Thus, the importance is that usually in an elderly individual and bilateral situation, so a wrong diagnosis can be avoided. Another OCT biomarker in the choroid is something called posterior choroidal loculation of fluid in CSC, which is seen in around 60% of the eyes with CSC. Spade was the first one to describe a dissociated form outside the pachyvessels and interdigitated form in between the pachyvessels out in the outer part of the posterior choroid. So we had published the first report of this posterior choroidal loculation presenting as a choroidal mass lesion or a choroidal elevation. So these are case examples where there is a choroidal elevation and it extremely thick choroid and the more than 800. So this happens usually when the choroid is overwhelmingly thick, more than 500 microns, and the extra fluid gets accumulated in the outer choroid, saturating the already saturated choroidal stroma. This is a lumpy, bumpy elevation subretinal fluid here. You see, and on treatment on lines of CSC, the choroidal elevation is disappeared. Again, one more patient with a inferior macular choroidal elevation. You see this lumpy, bumpy choroidal elevation, and this is the posterior choroidal loculation of fluid on Swepsore's OCT. And after treatment, it has resolved after 3 months. It's not a choroidal mass lesion. So one more biomarker in very recently using ONFAS OCT, it has been shown that there is intervortex anastomosis in CSC. In the choroid, there is intervortex anastomosis between the superior and inferior vortex vein systems. Normally, the horizontal raphe is not obliterated. When you see in CSC, you see this large caliber vessels obliterating the horizontal meridian. This is something called intervortex anastomosis. So ONFAS OCT without ICG can show this choroidal anastomosis, because this gives, especially in complex CSC, it is shown that the choroidal venous congestion happens, vortex vein congestion, and this is happening as a compensatory new drainage route to decongest the vortex vein congestion, and this brings us to the venous overload choroidopathy spectrum, including the bullous CSC and uveal effusion syndrome. Coming to the OCT angiographic findings that has been described in the inner choroid of CSC are dark areas, dark spots, and abnormal choroidal vessels. So these are the dark areas in the inner choroid and choroidal segmentation. Usually it is seen to overlay the area of Pachy vessels and considered to be suggesting inner choroidal ischemia in the setting of chronic CSC. So this could be the pathology in chronic CSC. You have this inner choroidal ischemia and abnormal choroidal vessels in the inner choroid in the form of a ball of wool pattern or an indistinct angle pattern. These are secondary subtle neovascularization that is picked up on OCTA, but it may be missed on the conventional fluorescent angiography because of the dye leakage, diffuse dye leakage. So this brings us to another type 1 CNVM. This is a de novo, this is not a secondary CNVM, this is a de novo type 1 neovascularization. There is an occult CNVM and a hotspot on ICG, and there is a thick choroid, hyperpermeable choroid, and you have a type 1 CNVM there. This is Pachy neovasculopathy. For example, this was diagnosed as first episode of chronic CSR non-resolving. When you see the swept source OCT, you see the flat irregular PED with a hyperreflectivity overlying Pachy vessels and subretinal fluid. And then when OCTA, this is a superficial deep segmentation, all normal. When you do a sub-RP segmentation, you find this tangled network of neovascularization giving the diagnosis of Pachy neovasculopathy, usually overlying the flat irregular PED. So OCTA is highly sensitive in picking up this neovascularization, whether the first type which we mentioned as secondary CNVM in the setting of a chronic CSU or a de novo neovascularization as Pachy neovasculopathy. So in PCV also the OCT and OCTA combination has revolutionized the serosanguinous maculopathy. ICG used to be the gold standard with hyperfluorescent nodular lesions in the first 1 to 3 minutes, but now we have a non-invasive non-ICG criteria where the three major criteria including sharp peak PED, sub-RP ring-like structure and a complex RP elevation on on-fast OCT, and along with the other findings of orange subretinal nodule and subretinal hemorrhage and other findings, double layer sign, all these things giving the diagnosis with almost 80% accuracy compared to ICG angiography. And in the revised recommendation, the complex RP elevation on on-fast imaging, because on-fast imaging has to be segmented and difficult for the retinologist, so it has been replaced with orange subretinal nodule on color fundus photography with 85% accuracy, almost comparable to the initial criteria for diagnosis. These are some case images, the classic notched PED with sub-RP ring-like structure, a tall peaked notched PED, or a thumb-like PED, or you have a double layer sign with separating the RP from the Brooks membrane. So also these patients can have serous PED. So serous PED is on ICG showing a polyp at the inferior edge of the PED, but then these are not CSC PEDs. This respond well to after switching to aflibercept injection. So it has to be kept in mind that serous PEDs like this or with a notch PEDs can have coexisting CSR in one area and inferior polypoidal lesion, because both belonging to the same spectrum of diseases, the pachychoroid disease spectrum. So again, one more OCT finding is a hemorrhagic PED with a intraretinal hyperreflectivity and backshadowing. So this is a hemorrhagic PCV. So if the subretinal thickness of the blood is less than 400 microns in the study conducted showed that with intensive anti-VEGF monotherapy without gas displacement can have good vision like this if treated early. So OCTA can very well pick up the branching neovascular network. The polypoidal lesions are not greatly picked up because they are low flow lesions compared to the ICG angiography. So because many clinics lack ICG and PDT currently, so we could combine OCT and OCTA and then go ahead with intravitreal monotherapy, and then the PDT rescue and ICG can be reserved for persistent polypoidal lesions. So the last entity is focal choroidal excavation, which is a sharp excavation in the choroid with or without attached neurosensor retina. This is a non-conforming type, this is a conforming type, but the importance is that these patients could harbor neovascularization, and it requires only a few injections for these to respond very well in the pachychoroid spectrum of diseases. So to summarize, so it is important to understand the imaging criteria of pachyepitheliopathy because these patients can develop CSC. Pachy vitiliform maculopathy, because they need very careful follow-up. They can proceed later to pachychoroid geographic atrophy. CSC with the swept source OCT, the various phenotype as well as the disease mechanism is being unraveled now. And the chronic CSC and the peripapillary Pachy syndrome, the half-dose PDT is the current gold standard, as we saw in some of those patients. Pachy neovasculopathy, secondary CNVM and FC related CNVM, OCTA is very important because the conventional angiography sometimes may miss it. And PCV, it's a non-invasive imaging criteria now, anti-VEGF monotherapy, and ICG and PDT reserved for persistent polypoidal lesions. Thank you.
Thank you, George, for that excellent talk. Our Pachy man from India. George, I have just a few questions for you as Dr. Harshad is getting ready. One, is there any biomarker which points out to the fact that this is a PCN, a pachychoroid neovasculopathy? One. Two, do biomarkers help us to decide which is the anti-VEGF of choice, in, for example, in the setting of PCV? And third is pachychoroid, peripapillary pachychoroid syndrome. What is the treatment of choice?
So, as I already mentioned in the talk, actually, the PCN combination of OCT and OCTA is very important, because the presentation is almost the same like the case which was referred, only a referral for PDT in the setting. But then when we image with an OCT and combination of OCTA, it turned out to be a neovascularization. So that is very important. So it may be in the absence of any history of CSC also. Patient could just present with the first presentation. It need not always go from pachyepitheliopathy to CSC, then to PCN, and no. Patient can present directly in the setting. So it's very important to combine. So that was the first question. And then, so for PCV, actually, now in the age when we had only the ranibizumab and Avastin, it has shown that the polyp regression or the treatment success. Now, how do you define treatment success is, nowadays, because it's OCT criteria, people look at injections and say that macula is dry, and that is what we call as polyp inactivation. But then that is a pseudo feeling of success. But then you have to look at the polyp closure rate, because when it has been studied over 2 to 3 years, the recurrence and rebleed and loss of vision is very high. So that is why it's important that these patients at some point so it need not be in the first 6 months, but at some point we have to look at where the polyp regression is there. So now it is anti-VEGF monotherapy. We have much better anti-VEGF. For example, we have aflibercept, or now even brolucimab, or now the faricimab has shown almost 60% with the, it is very important to have loading doses, and the treatment success is much more. But then we need to re-evaluate it after 6 months. Any of these patients undergoing treatment, initially the loading doses, and then once you stop, you need to re-evaluate whether it's only an inactivation or is it a real thing. And the last question, which peripapillary pachychoroid syndrome is a variant of CSC, and usually, as I showed images, it's important to diagnose. So this is one condition wherein none of the other treatment modalities work actually. If you try focal laser or epilineron or any other things, it doesn't work. The only thing that has shown to work in our hands is photodynamic therapy.
Thank you.